Question 1. A 28-year-old prima gravida at 34 weeks with severe preeclampsia is receiving a continuous infusion of magnesium sulfate at 2g/hr. Which assessment finding requires the nurse to immediately stop the infusion? A. Urine output 35 milliliters per hour. B. Respiratory rate 10 per minute. C. Blood pressure 150/92 mmHg. D. 1 plus proteinuria. Answer. B. Respiratory rate 10 per minute. Rationale: respiratory depression, less than 12 per minute, indicates magnesium toxicity and requires immediate discontinuation and intervention. Question 2. A nurse is monitoring a client on magnesium sulfate therapy. Which parameter best reflects early magnesium toxicity? A. Hyperactive deep tendon reflexes. B. Decreased urine output. C. Loss of deep tendon reflexes. D. Tachycardia. Answer. C. Loss of deep tendon reflexes. Rationale: loss of DTRs is an early and sensitive indicator of magnesium toxicity. Question 3. A patient receiving magnesium sulfate develops absent patellar reflexes. What is the nurse's priority action? A. Administer oxytocin. B. Stop magnesium sulfate infusion. C. Increase 4 fluids. D. Place patient in Trendelenburg. Answer. B. Stop magnesium sulfate infusion. Rationale: absent reflexes indicate toxicity. Stop infusion immediately to prevent progression. Question 4. Which antidote should be readily available at the bedside for a patient receiving magnesium sulfate? A. Potassium chloride. B. Calcium gluconate. C. Sodium bicarbonate. D. Naloxone. Answer. B. Calcium gluconate. Rationale: calcium gluconate reverses magnesium toxicity effects. Question 5. A nurse notes a client on magnesium sulfate has urine output of 20 milliliters per hour for the past 2 hours. What is the most appropriate action? A. Continue infusion. B. Increase infusion rate. C. Notify provider. D. Encourage oral fluids. Answer. C. Notify provider. Rationale: oliguria increases risk of magnesium accumulation and toxicity. Question 6. Which clinical finding indicates therapeutic magnesium sulfate level? A. Seizures present. B. Hyperreflexia. C. Reduced neuromuscular excitability. D. Severe hypertension. Answer. C. Reduced neuromuscular excitability. Rationale: magnesium works by depressing CNS and preventing seizures. Question 7. A client receiving magnesium sulfate reports feeling flushed and warm. What is the nurse's best response? A. This indicates toxicity. B. This is an expected side effect. C. Stop infusion immediately. D. Prepare antidote. Answer. B. This is an expected side effect. Rationale: flushing and warmth are common benign effects. Question 8. Which assessment finding suggests worsening magnesium toxicity? A. Respiratory rate 14 per minute. B. DTR 2+. C. Oxygen saturation 98%. D. Respiratory rate 8 per minute. Answer. D. Respiratory rate 8 per minute. Rationale: severe respiratory depression signals advanced toxicity. Question 9. A nurse is preparing to administer magnesium sulfate. Which baseline assessment is most critical? A. Fundal height. B. Deep tendon reflexes. C. Fetal sex. D. Maternal weight. Answer. B. Deep tendon reflexes. Rationale: baseline DTR allows comparison for toxicity detection. Question 10. Which lab value is most important to monitor during magnesium therapy? A. Hemoglobin. B. Platelets. C. Serum magnesium level. D. Sodium. Answer. C. Serum magnesium level. Rationale: ensures therapeutic, 4 to 7 milliequivalent/L, and prevents toxicity. Question 11. A client at 36 weeks with severe preeclampsia is on magnesium sulfate. The nurse notes slurred speech and increasing somnolence. What is the nurse's priority action? A. Reassure the client this is expected. B. Discontinue magnesium sulfate infusion. C. Administer antihypertensive medication. D. Encourage deep breathing exercises. Answer. B. Discontinue magnesium sulfate infusion. Rationale: CNS depression, slurred speech, somnolence, indicates toxicity requiring immediate discontinuation. Question 12. A nurse is assessing a patient receiving magnesium sulfate. Which combination of findings indicates toxicity? A. RR 16 per minute, DTR 2+, UO 40 ml per hour. B. RR 12 per minute, DTR 1+, UO 35 ml per hour. C. RR 10 per minute, absent DTR, UO 25 ml per hour. D. RR 18 per minute, brisk DTR, UO 50 ml per hour. Answer. C. RR 10 per minute, absent DTR, UO 25 ml per hour. Rationale: classic triad of toxicity, respiratory depression, absent reflexes, oliguria. Question 13. A postpartum client continues magnesium sulfate infusion for seizure prophylaxis. Which duration is most appropriate? A. 6 hours postpartum. B. 12 hours postpartum. C. 24 hours postpartum. D. Until BP normalizes. Answer. C. 24 hours postpartum. Rationale: standard care is continuation for 24 hours postpartum to prevent eclampsia. Question 14. Which fetal effect is most concerning during maternal magnesium sulfate therapy? A. Fetal heart rate variability reduction. B. Fetal tachycardia. C. Increased fetal movement. D. Polyhydramnios. Answer. A. Fetal heart rate variability reduction. Rationale: magnesium depresses CNS decreased variability. Question 15. A nurse is caring for a client on magnesium sulfate who suddenly develops a seizure. What is the first action? A. Administer calcium gluconate. B. Call rapid response team. C. Turn the client aside. D. Increase magnesium infusion. Answer. C. Turn the client aside. Rationale: priority is airway protection and preventing aspiration. Question 16. A client receiving magnesium sulfate has a serum magnesium level of 9 milliequivalent/L. What should the nurse anticipate? A. Therapeutic effect. B. Mild side effects only. C. Toxicity requiring intervention. D. Subtherapeutic level. Answer. C. Toxicity requiring intervention. Rationale: 7 milliequivalent/L increases risk of toxicity, 9 is dangerous. Question 17. Which medication should the nurse question in a client receiving magnesium sulfate? A. Labetalol. B. Hydralazine. C. Nifedipine. D. Acetaminophen. Answer. C. Nifedipine. Rationale: combined use may cause severe hypotension due to additive effects. Question 18. A nurse is monitoring a client on magnesium sulfate. Which finding requires immediate intervention? A. BP 140/90 mmHg. B. DTR 2+. C. Urine output 25 ml per hour. D. Mild headache. Answer. C. Urine output 25 milliliters per hour. Rationale. Low urine output leads to accumulation and toxicity. Question 19. Which assessment finding indicates therapeutic effectiveness of magnesium sulfate? A. Increased blood pressure. B. Absence of seizures. C. Increased reflexes. D. Tachypnea. Answer. B. Absence of seizures. Rationale. Primary goal is seizure prevention. Question 20. A client receiving magnesium sulfate complains of difficulty breathing. What is the nurse's priority action? A. Reassure the patient. B. Stop infusion and assess respiratory status. C. Administer oxygen only. D. Call family. Answer. B. Stop infusion and assess respiratory status. Rationale. Dyspnea may indicate respiratory depression, urgent assessment and stopping infusion required. Question 21. A nurse is caring for a client on magnesium sulfate infusion for seizure prophylaxis. Which assessment finding most strongly indicates impending respiratory arrest? A. DTR 1+. B. Respiratory rate 11 per minute. C. Serum magnesium level 6 milliequivalent/L. D. Respiratory rate 6 per minute. Answer. D. Respiratory rate 6 per minute. Rationale. Severe respiratory depression, less than 8 per minute, signals life-threatening toxicity and risk of arrest. Question 22. A client receiving magnesium sulfate suddenly becomes unresponsive with absent reflexes. Which medication should the nurse prepare to administer immediately? A. Naloxone. B. Calcium gluconate. C. Epinephrine. D. Atropine. Answer. B. Calcium gluconate. Rationale. Calcium gluconate is the antidote for magnesium toxicity and reverses neuromuscular depression. Question 23. A nurse is evaluating urine output in a patient receiving magnesium sulfate. Which hourly output is the minimum acceptable to safely continue therapy? A. 20 milliliters per hour. B. 25 milliliters per hour. C. 30 milliliters per hour. D. 50 milliliters per hour. Answer. C. 30 milliliters per hour. Rationale. Minimum of 30 milliliters per hour ensures adequate renal excretion of magnesium. Question 24. Which maternal assessment finding reflects a therapeutic level of magnesium sulfate? A. Absent deep tendon reflexes. B. Respiratory depression. C. Slightly diminished reflexes, 1+. D. Seizure activity. Answer. C. Slightly diminished reflexes, 1+. Rationale. Mild reduction in reflexes indicates therapeutic CNS depression without toxicity. Question 25. A nurse notes a client receiving magnesium sulfate has a blood pressure of 88/54 mm of mercury. What is the nurse's priority interpretation? A. Expected therapeutic effect. B. Sign of magnesium toxicity. C. Normal pregnancy change. D. Effect of labor pain. Answer. B. Sign of magnesium toxicity. Rationale. Hypotension may occur due to excessive magnesium levels causing vasodilation. Question 26. Which intervention is essential when initiating magnesium sulfate therapy? A. Continuous fetal monitoring. B. Restrict fluid intake. C. Encourage ambulation. D. Provide high-protein diet. Answer. A. Continuous fetal monitoring. Rationale. Magnesium affects fetal CNS, monitoring ensures fetal well-being. Question 27. A nurse is caring for a client on magnesium sulfate who has newly developed blurred vision. What should the nurse do first? A. Document finding. B. Reassure patient. C. Assess for toxicity and notify provider. D. Provide eye drops. Answer. C. Assess for toxicity and notify provider. Rationale: visual disturbances may indicate worsening condition or toxicity. Question 28. Which electrolyte imbalance increases the risk of magnesium toxicity? A. Hypernatremia. B. Hypocalcemia. C. Hyperkalemia. D. Hypophosphatemia. Answer. B. Hypocalcemia. Rationale: low calcium enhances magnesium's neuromuscular blocking effects. Question 29. A nurse observes that a client on magnesium sulfate has become increasingly lethargic. What is the priority nursing assessment? A. Blood glucose. B. Deep tendon reflexes. C. Fundal height. D. Fetal position. Answer. B. Deep tendon reflexes. Rationale: lethargy may indicate CNS depression. DTR helps confirm toxicity. Question 30. Which equipment must be immediately available at the bedside of a client receiving magnesium sulfate? A. Suction equipment and oxygen. B. Glucometer. C. Ambulation aids. D. Heating pad. Answer. A. Suction equipment and oxygen. Rationale: risk of respiratory depression and seizures requires airway support readiness. Question 31. A client with severe preeclampsia is receiving magnesium sulfate. The nurse notes the client suddenly reports chest heaviness and has a respiratory rate of 9 per minute. What is the nurse's priority action? A. Elevate the head of the bed. B. Stop magnesium sulfate infusion. C. Administer antihypertensive medication. D. Check fetal heart rate. Answer. B. Stop magnesium sulfate infusion. Rationale: respiratory depression indicates toxicity. Immediate discontinuation is critical. Question 32. A nurse is reviewing lab results for a client receiving magnesium sulfate. Which value indicates a therapeutic range? A. 2 to 3 milliequivalent/L. B. 4 to 7 milliequivalent/L. C. 8 to 10 milliequivalent/L. D. 10 to 12 milliequivalent/L. Answer. B. 4 to 7 milliequivalent/L. Rationale: this is the safe therapeutic range for seizure prevention. Question 33. A client on magnesium sulfate develops absent deep tendon reflexes but maintains a respiratory rate of 14 per minute. What is the nurse's best action? A. Continue infusion. B. Reduce infusion rate. C. Stop infusion and notify provider. D. Document as expected. Answer. C. Stop infusion and notify provider. Rationale: loss of reflexes is an early toxicity sign, even without respiratory depression. Question 34. Which finding indicates worsening preeclampsia despite magnesium therapy? A. Stable blood pressure. B. Absence of seizures. C. Persistent severe headache. D. DTR1+. Answer. C. Persistent severe headache. Rationale: ongoing neurological symptoms indicate disease progression. Question 35. A nurse is caring for a client on magnesium sulfate with a urine output of 28 milliliters per hour. What is the nurse's priority interpretation? A. Adequate renal function. B. Risk for toxicity. C. Normal pregnancy finding. D. Expected medication effect. Answer. B. Risk for toxicity. Rationale: output less than 30 milliliters per hour increases magnesium accumulation risk. Question 36. Which assessment finding most strongly supports magnesium sulfate effectiveness? A. Hyperreflexia persists. B. No seizure activity. C. Elevated blood pressure. D. Increased urine output. Answer. B. No seizure activity. Rationale: primary goal is seizure prevention. Question 37. A nurse prepares to administer calcium gluconate. Which situation justifies its use? A. Blood pressure 150/90 mmHg. B. Respiratory rate 16 per minute. C. Absent deep tendon reflexes. D. Mild flushing. Answer. C. Absent deep tendon reflexes. Rationale: indicates magnesium toxicity requiring antidote. Question 38. A client receiving magnesium sulfate becomes difficult to arouse. What is the nurse's priority next step? A. Assess respiratory rate. B. Check blood pressure. C. Notify provider. D. Document findings. Answer. A. Assess respiratory rate. Rationale: airway and breathing are priority, assess for respiratory depression first. Question 39. Which intervention helps reduce the risk of complications during magnesium sulfate therapy? A. Encourage ambulation. B. Strict intake and output monitoring. C. Limit fetal monitoring. D. Increase environmental stimuli. Answer. B. Strict intake and output monitoring. Rationale: ensures adequate renal excretion and prevents toxicity. Question 40. A nurse notes that a client on magnesium sulfate has stable vital signs, DTR2+, and urine output 45 ml per hour. What is the appropriate nursing action? A. Stop infusion. B. Continue therapy. C. Administer antidote. D. Notify provider immediately. Answer. B. Continue therapy. Rationale: findings are within safe therapeutic parameters. Question 41. A client receiving magnesium sulfate suddenly develops apnea. What is the nurse's first action? A. Administer calcium gluconate. B. Initiate bag valve mask ventilation. C. Stop magnesium infusion. D. Call the provider. Answer. B. Initiate bag valve mask ventilation. Rationale: airway and breathing take absolute priority, support ventilation immediately before other interventions. Question 42. A nurse notes a client on magnesium sulfate has a serum level of 7.5 milliequivalent/L. What is the most appropriate interpretation? A. Subtherapeutic. B. Therapeutic but approaching toxicity. C. Critically low. D. Normal pregnancy level. Answer. B. Therapeutic but approaching toxicity. Rationale: upper therapeutic range, requires close monitoring. Question 43. A postpartum client is receiving magnesium sulfate. Which assessment finding indicates safe continuation of therapy? A. Urine output 20 ml per hour. B. Respiratory rate 14 per minute. C. Absent DTR. D. Extreme lethargy. Answer. B. Respiratory rate 14 per minute. Rationale: normal respiratory rate supports safe continuation. Question 44. Which clinical situation increases the risk for magnesium sulfate toxicity the most? A. Multiparity. B. Renal insufficiency. C. Gestational diabetes. D. Obesity. Answer. B. Renal insufficiency. Rationale: magnesium is excreted via kidneys, impaired function leads to accumulation. Question 45. A nurse is caring for a laboring client on magnesium sulfate. Which reflex should be routinely assessed? A. Babinski reflex. B. Patellar reflex. C. Corneal reflex. D. Gag reflex. Answer. B. Patellar reflex. Rationale: deep tendon reflex, patellar, is the most sensitive for early toxicity detection. Question 46. A client on magnesium sulfate has DTR 0 and respiratory rate 13 per minute. What is the priority action? A. Continue therapy. B. Reduce infusion rate. C. Stop infusion. D. Encourage fluids. Answer. C. Stop infusion. Rationale: loss of reflexes equals early toxicity even if respirations are normal. Question 47. Which fetal heart rate pattern is expected in a client receiving magnesium sulfate? A. Marked variability. B. Decreased variability. C. Recurrent late decelerations. D. Persistent tachycardia. Answer. B. Decreased variability. Rationale: magnesium depresses CNS reduced variability. Question 48. A nurse is monitoring a client with eclampsia on magnesium sulfate. Which outcome indicates therapy is effective? A. Blood pressure normalizes. B. Reflexes increase. C. No seizure recurrence. D. Urine output increases. Answer. C. No seizure recurrence. Rationale: primary goal is seizure prevention, not BP normalization. Question 49. A nurse prepares to discontinue magnesium sulfate. Which parameter confirms it is safe? A. Serum magnesium 9 milliequivalent/L. B. DTR absent. C. Respiratory rate 16 per minute and stable. D. Urine output 20 milliliters per hour. Answer. C. Respiratory rate 16 per minute and stable. Rationale: stable respirations indicate no respiratory compromise. Question 50. A nurse is caring for a client on magnesium sulfate who suddenly develops hypotension, bradycardia, and respiratory depression. What is the priority sequence of interventions? A. Stop infusion calcium gluconate airway support. B. Airway support stop infusion calcium gluconate. C. Calcium gluconate stop infusion oxygen. D. Notify provider stop infusion monitor. Answer. B. Airway support stop infusion calcium gluconate. Rationale: ABCs first, airway/breathing, then remove cause, then administer antidote. You've just completed one of the most high-yield, high-risk topics in obstetric nursing. Magnesium sulfate management. If you can confidently recognize early versus late toxicity, critical reflex changes, life-saving priority actions, then you're thinking exactly like an NCLEX examiner expects. Stay sharp, stay clinical, and never miss the silent signs that save lives.